Welcome to PEM Chat. This is a peer-to-peer educational podcast about pediatric emergency medicine for the advanced practice provider. My name is Toni Dobson, and I am located in Chattanooga, Tennessee, and I will be your host. Welcome back, everybody, to the PEM Chat podcast. I'm glad you're here. Today, we're going to be talking about drowning, and it is one of those injuries that really feels uniquely heartbreaking because it's one of those things that typically happens right under the nose of a parent or a caregiver. It's never a pleasant scene in the emergency department when there's a pediatric arrest that comes in, but I feel like these are particularly gut-wrenching. In the U.S., drowning is one of the number one causes of unintentional injury or death in children ages 1 to 4. And the second leading cause of school-aged injury death for kids. And every year, approximately 4,000 children die from an unintentional drowning right here in the United States. Now, for kids who survive these injuries, the story is far from over, right? Non-fatal drowning can leave you with a hypoxic brain injury or a chronic disability, months, years of rehab for families who thought that they were just headed out for the afternoon at the pool. So to help us unpack this issue today, I have a very special guest, Dr. Sarah Lazarus, and she is a pediatric emergency department physician in Atlanta, Georgia. Thank you so much, Sarah, for joining us today.
Thank you so much for having me, and I'm really excited, and this is just such an important topic.
Yeah. Tell us a little bit about yourself, and just for fun, share something that you're passionate about outside of medicine.
Yeah, I work with Pediatric Emergency Medicine Associates in Atlanta. I work at Children's Healthcare of Atlanta and Wellstar Hospitals. I did my residency and fellowship at Emory University in Atlanta, and I am truly an Atlanta local. I was born in Atlanta, which is, I think, rare
Unusual,
nowadays.
right?
Yeah. I also have 12-year-old twins, which is fun and has also given me a whole different view of pediatrics and pediatric emergency medicine. As you can say all the things before you have children, and it changes a bit once they're in your care.
That's the
Yeah, no question. And I am obsessed with the food bread pudding. I've had 150 different varieties. I went to college in New Orleans where I really got to know the food, and that would be my one weird, strange passion.
Okay, where did you go to college?
Tulane University.
Oh, I went to Loyola. I grew up in New Orleans.
Did you? I
Yeah.
had no idea.
Yeah, and I love bread pudding too. So what's your favorite bread pudding?
I don't think they have it anymore, but there was a House of Blues New Orleans bread pudding off bourbon. It might have been on Chartis, actually, but it was a white chocolate banana bread pudding that was
Oh, that
just
sounds
mind-blowingly
awesome.
good. Yeah. In
Any
Atlanta,
white
there's a
chocolate
good
ones.
fig one that's good that I really like.
Oh, where?
It's called Boone's. It's in right off Piedmont Park. It's like a random golf shop.
Okay. We have a giant fig tree in our front yard, and I make fig jam every year, so I'll have to send you some. So we seek out fig stuff. I just
Yeah.
saw on Instagram yesterday, there's a restaurant in New Orleans that makes fig-filled king cake for,
Oh, snap. That might be what I have to do next.
yeah, for sure. I was going to look this afternoon and just see if they ship so that we could get it. So,
It's a
yeah,
great question.
small world.
Yeah.
All right. I'm glad you're here to talk to us about submersion injuries. These, I think, can be really scary visits for people. And before I worked at Children's, I'm not sure that I realized that it was so algorithmic. I love that about it. But anyway, before we jump in, talk to us about terminology. I feel like drowning, submersion, fatal, non-fatal. Just define all that for us and tell us what all that stuff means.
Yeah. So there used to be over 20 definitions for drowning, and really they've tried to narrow it down because it just became more and more confusing. So people would use the terms fatal, non fatal, which we still do use submersion injury or drowning and then divide it into fatal and non fatal. But things they would say would be near drowning, dry drowning, wet drowning. And none of those were really good descriptors of what drowning looked like or what the prognosis or outcomes would be. So they really have brought it down to either submersion injury or drowning. And then once within that drowning realm, it's drowning either fatal or not fatal.
When we talk about drowning, who is most at risk?
Yeah, so we know that children ages 1 through 4, this is the leading cause, the number one cause of death in this age group. So that would be the biggest risk factor. We also know that males are more common to drown than females. And we think that this may be due to some risk taking behaviors that start very young. But interestingly, that is true of a lot of injuries. It's true of gunshot wounds, it's true of even sleep related deaths, that there is a male predominance there. We also know that there are racial disparities for multitudes of reasons, with Black males more commonly drowning than white females.
That's not something I really thought about before I prepared for this podcast. What lends that to be true?
There are so many socioeconomic and historical factors. First of all, just being that when you look back at the slave trade, all the way back then, children were told to stay away from the water. They could be grabbed, they could be sold. And so this fear of water was actually was required for their own safety and survival. And so many families didn't learn to swim going forward to when there was no pool access for Black families. They weren't given pool access, so then they didn't learn the skills then. So there are so many historical and racial features that unfortunately have continued to keep these disparities present.
Okay, last night I listened to a podcast that you were on in 2022 for CHOA about drowning. And what really resonated with me about that podcast was the guest who talked about her child that had a drowning episode, Melissa Gibson. And she recounted the story of her 2-year-old daughter drowning in a pool at a birthday with a million people there. Like they had done everything right as parents to protect their kid. And yet she slipped outside and had this drowning episode. She lived and survived and did well. But she talked about how it was quiet. And I thought that was really interesting because I hadn't really thought about it before. No splashing, it's not like the movies. Tell us how that looks like in reality and then go through like the pathophysiology of how somebody drowns, if you will.
Yeah, so it's so interesting because just like you said in the movies, there's splashing, there's movement. If people have the ability to do all that, they're generally able to keep themselves and their head above water. A lot of times, what I'll hear or what I've heard in the past from parents who have brought their children in after drowning is the child was almost like spinning slowly until their mouth and nose were just slowly covered. Like they couldn't quite just keep themselves kind of above water. So it is silent, it's quick. It can happen in as little as 30 seconds. And it can happen in very little water, an inch and a half of water, because all it takes is really this aspiration event. So, what that pathophysiology is, first, there's a submersion. So they have to have their mouth, nose underwater. And then basically where they breathe in, and then this causes respiratory impairment. So they breathe in and water goes into the airway. Now, this can cause either what we call laryngospasm, which is when the airway, the vocal cords kind of freeze and you can't take a breath. And in that case, that's where that term dry drowning came from, because there was not actually an aspiration of water right at that time. It came later after that laryngospasm eventually aborted when someone lost consciousness. So there can either be this laryngospasm or there can be basically an aspiration. And either way, at the end of that laryngospasm, because if you lose consciousness, that laryngospasm will stop and it will go away, then you will aspirate and breathe in water. And at that point, that will cause aspiration. So basically, regardless of whether you have a laryngospasm or just a straight up aspiration, water gets into the lungs. That causes a washout of what we call surfactant, which is kind of like this chemical that protects the lungs on the inside. And then that causes oxygen and carbon dioxide to mismatch, and then you're not breathing well. It can cause what we call pulmonary edema, which is water gets into the lungs and things get really wet. And then that surfactant getting washed causes that to increase and increase. And you basically get more and more suffocated with less oxygen going in and less carbon dioxide going out.
Yeah, interesting. This type of injury affects lots of body systems. As a clinician, if we're assessing these patients when they come in after an event, what do I need to be paying attention for? What needs to be on my differential outside of just the lungs?
Yeah. So, of course, we always start with the ABCs as ER people, where, airway, breathing, circulation, those are the first three things. But it can really affect all body systems, starting neuro. There may be a loss of consciousness, there may be hypoxic injury. So, if a child has been submerged for any period of time and they lost consciousness, they can be deprived of oxygen, especially if they required CPR. And that can lead to stroke like symptoms. So, basically, deficits on one side or the other, or significant developmental back progress. They can also have as respiratory issues. They can have arrhythmias. So we know that electrolyte abnormalities, so salt being low or potassium being high, which can be caused by these kind of cardiac events or them being submerged for a period of time, can then lead to different types of heart function being either too fast or too slow or not present. It can also, we know that there's something called QT prolongation that can happen from basically diving, or we know that can be associated with drowning, but it's actually the heart that leads to the drowning incident. There can be electrolyte abnormalities, like we talked about. So, if you drink a ton of water or aspirate a ton of water, the salt levels in your blood goes down, and that can lead to seizures or issues with your heart. And there can be kidney and liver shock. So basically, you can get kidney dysfunction or liver abnormalities after any sort of deprivation of oxygen.
When it comes to resuscitation efforts, does it matter if the patient was exposed to, say, fresh water versus salt water?
We used to think that it might be better if it was salt water, but we really now know that it doesn't matter. There's no real better or worse depending on whether salt water or fresh water. The electrolyte abnormalities may be greater if there's large amounts of either, but it doesn't matter which type. And we also now know that cold water isn't necessarily protective. We used to think that maybe cold water was protective, and it can be. Possibly, but we're really not even sure if that's true, because definitely prolonged effects of hypothermia are very dangerous as well.
Yeah. In my mind, there's three categories of these patients. There's the kid that comes in that had an exposure that has no symptoms and they look good. Parents are just worried. There's the kid that comes in that has like mild symptoms. Maybe they're a little tachypnic. And then there's the kid that comes in full cardiac arrest. Let's run through each of these sort of situations. I'm going to give you like a little scenario and talk me through your assessment for this kid, your management plan, and then we'll go through a disposition for each of these.
I love that. And I would also say there's the fourth category, which is just they swallowed a little water at swimming lessons and parents are worried about dry drowning,
Yeah.
which is like the hardest one because there's nothing to do. And that's not a drowning because they never had an aspiration and never experienced respiratory impairment, which is the whole definition there.
That's on my list. It's just
Oh,
different.
perfect.
Okay. So, patient one is a 4-year-old male. He was at the pool today, went under the water. Parents didn't see him come back up, but they were right there. And it was just a short period of time. They weren't sure how long, but they were able to pull him out of the water pretty quickly. He coughed a lot and then threw up some water on the side of the pool, but he seems fine. He's been acting fine. Of course, parents were worried because this seemed like a drowning, and so they brought him in just to be safe. Talk me through your assessment of this patient and what you're going to do.
So I would argue that this was a true aspiration event. We know he was coughing, so that shows signs of basically bronchospasm or irritability of the airway after getting water in it. And then he vomited, which both goes with what we typically see with a submersion event. So in this case, we have come up at Children's Healthcare of Atlanta with a nice little algorithm that we want to watch them for 6 hours after the event. And if they do not develop tachypnea, if they're not having significant coughing, if they're not wheezing, if they're not in any respiratory distress, if their SATs remain over 94%, then they are able to go home without any further intervention. No chest x-ray, no blood gas. We know that they've been watched for a significant period of time, that the drowning did not cause any sequelae.
Is it 6 hours from the time of the event or 6 hours in your ER?
Great question. That was a big discussion when we came up with this protocol, but 6 hours from the time of the event.
Okay. So if they come in 8 hours post and they were like, just look at my kid and they look great, we're done.
You're done,
Okay.
exactly. And no need for, it's really hard sometimes to argue against the chest x-ray. Some parents really feel strongly that they want that chest x-ray, but unfortunately it can show subtle abnormalities that probably aren't related to this event, and then you're stuck. So we really have tried to decrease X-ray utilization on these asymptomatic kids if it's 6 hours post and they're asymptomatic.
If the parent is insistent and you're going to fold to this, would you try to talk them into doing the chest x-ray later rather than earlier?
Yes, so usually I would try to get it right at the end of the observation stay.
Okay. If there are abnormalities, that kind of triggers more. So that's what you're saying. You get stuck.
You get stuck.
Yeah.
So we did a case review of a lot of these kids because I had always been told, and before we developed this protocol, that probably you should always just get a chest x-ray and a blood gas if you have an event like this. And I would get the blood gas originally, and I would get the chest x-ray at 6 hours after. And if both were fine, then they could still go home. However, we found that a lot of these kids had chest x-ray abnormalities that were very minor, maybe related, maybe not. And then we would admit them and they would spend less than 24 hours in the hospital and never require oxygen or any interventions and go home. So we were doing these x-rays, we were admitting based on these findings potentially, and there were no interventions happening, and it was increasing unnecessary admission stays. And some of these kids were being treated with antibiotics, which
Mm.
we know is really not necessary if there was a drowning in something like a pool or even an ocean. And we were providing unnecessary doses of antibiotics, which never is great.
Yeah. I feel like this is a thing with abdominal pain too, because parents are like, but what if it's this? And I'm like, I'm not going to look for something that I don't think is there because
Right.
then you get a CT scan.
Yeah,
It's just,
exactly. Then
it's
you're
just,
stuck.
yeah, it's like a recipe for a disaster. Okay, great. Patient number 2 is a 9-month-old female. Her parents brought her in because she was having some breathing difficulties. They noticed she was looking a little tachypnic and labored at home. She was taking a bath a few hours earlier. The dad just stepped out of the room for just a second, and when he got back, she was face down in the bathtub. He scooped her up immediately, and she was startled, but she seemed okay. They've been watching her closely, and then when her breathing looked abnormal, they decided to come to the ER. They are regretful they didn't come in earlier, but they thought she was fine. And when you look at her and do your first survey, you notice that she is a little bit tachypnic. She looks a little labored. She has some retractions, and her room air SpO2 is 89%.
So this is a kid we know had asymptomatic drowning. They will be admitted. They are already showing signs of hypoxia and respiratory distress. And how many hours ago did we say this occurred?
They said a few. I don't know.
Okay.
3.
So, within that first 6 hours, that's really the time that they're going to show their true colors and worsen. So, if we're 3 hours in and we're already having these features, then we know that things may get worse at 6 hours. And if they're that bad at 6 hours, over the first 24 hours, things can be pretty rocky. So, this is a kid you definitely will get a blood gas and chest x ray on at minimum. You'll start oxygen, usually low flow to start, but if they're still working or in distress, high flow or even BiPAP. Positive pressure can help kind of tamponade that pulmonary edema or that wetness in the lungs. And you could even consider, based on this story, just getting some basic labs to check for like electrolyte abnormalities, any sort of liver, kidney dysfunction. But they would definitely come into the hospital.
And for any of my community ED friends out there that are listening, we talk a lot about high flow nasal cannula and peds. But what I didn't know was that it's vapotherm, right? It's the same thing. We just call it something different on the adult side. Same kind of concept there. Okay, so we're doing more because this patient's symptomatic, and you would do all those things at the door?
If they're already hypoxic and in distress, then yes, that is one that I would just go ahead and do all the things for.
Is there utility in repeating that at the 6-hour mark? Does that, or is this an admission and then they do like a daily chest x-ray?
So this is an admission no matter what. No utility in doing as soon as a child that has a submersion develops those symptoms, go ahead and proceed with getting at least baseline imaging and blood gas. No need to repeat at 6 hours. It will look worse, but we want to treat them clinically just like we would with a pneumonia. They don't necessarily get a daily x ray if they're admitted. Again, it would look on clinical progression.
Hmm. And you mentioned that there's no reason to start antibiotics.
Right.
I was reading that some people, steroids used to be a thing.
Yeah, it's definitely not anymore. There's no utility in it. And even with like antibiotics, same thing, like more antibiotic resistance. Some of these kids have asthma, and I find that this type of event will trigger more of a status asthmaticus type
Mm,
issue. And if so, if you're hearing more wheezes than rhonchi or rales, then yeah, maybe you treat as an asthmatic kind of picture. But in general, yeah, steroids, antibiotics, not useful. Now, there are those cases where they drown in like a septic tank. And obviously, those kids
right.
probably do end up getting treated with antibiotics, regardless of what their labs or markers look like.
That's gross. Have you really seen that?
Yes.
Ah.
Yeah.
And you have to stop the
Gutters,
decon first.
septic tank. Yeah. Just nastiness.
Oh, that's terrible. I guess city sewers if a kid's running around and something like
Yeah.
that. Yeah, interesting.
Gross.
All right, great. So, patient number 3 is going to be our full on arrest. So, dad lives close to the hospital. The patient fell into their pool. They found her face down in the pool. They pulled her out, just ran in the ER door. You bring her in your trauma bay. You discover that she doesn't have a pulse. Nursing has already started CPR on this patient. Let's talk about how your differential is really different in an arrest for a submersion injury versus other types of arrests.
Yeah, so the biggest thing with submergent injuries is again the electrolyte abnormalities. So your H's and T's we talk about because they're usually not in shockable rhythms unless they had some sort of pre-existing arrhythmia that would lead to them having this drowning event. So really correcting the acidosis, correcting any sort of hypoxia, correcting their temperature because it's really important to realize that many of them are very cold. We like to say in the ER, although it's a horrible thing, you're not dead until you're warm and dead. So making sure that they're fully warmed. But the biggest thing with these guys, I find that if they're in full arrest like that, is the degree of pulmonary edema and fluid in their lungs is so severe. They're very hard to oxygenate and ventilate. Getting that tube early, intubating, and then several of these children that I've had that come in with arrest, if they've been able to be saved, have been moved to ECMO.
Yeah. And that's really becoming much more common, at least in children's facilities. You guys do it a
Yeah.
lot. I know we've been doing it more too.
Yeah, ECMO is basically a heart-lung bypass so that you don't need to work the lungs at all. So it really lets them rest and recover while they heal themselves from these submersion injuries.
So if you're managing that code, kind of reaching out to your surgical team or whoever initiates your ECMO early so that they can come in case you need to do it. Is there any place in these arrest situations where we've reached futility with regard to resuscitation? How do we know what's too long?
Yeah, I think we know, unfortunately, many of the kids that come in without a pulse from a submersion, if they've been coded for some period of time, had several rounds of epi, it is probably not, you could continue to push epi, but the long term prognosis, as far as neurologic prognosis, is very poor. As far as are they going to end up with a trach, an event? Are they going to walk or talk again? So, unfortunately, many times, if they come in fixed, dilated, cold, they've gotten 30 minutes of CPR, 3 or 4 rounds of epi, it's probably pretty futile.
Yeah, sad. Let's talk about C-spine. I know we're focused on like little kids right now and probably didn't have a diving injury, but it's something that when I was a paramedic, I was taught always put these kids in C-spine.
Yeah.
Do we need to be thinking about that?
That's such a good question. So the literature says no. The literature says very few of these are actually C-spine injuries. That being said, if you have a kid that's probably more like a 10 to 16-year-old, I think, of course, higher risk, especially if they came from a lake and they were on a dock. Like those kids are you should be more concerned about that type of situation. But the majority of these, especially in the toddler case, they really don't recommend doing C-spine immobilization. The yield is very low,
Yeah, that makes our job a little bit easier.
for sure.
Yeah. I read a lot about how the ventilation is so important here. And in like bystander CPR, we've kind of gotten away from that being a necessity. Can we use this as an opportunity to kind of educate parents a little differently in these situations?
I love that. You see, I feel like you like looked at all my stuff. If you look, New England Journal of Medicine has an algorithm that's very different for drowning than it does for typical kind of AHA cardiac arrest. And it starts with breaths. And it's really the only etiology where you want to start with breaths. So, yes, this is a respiratory emergency. And so, interestingly, New England Journal of Medicine is the one place I've kind of seen that algorithm. And they actually, and maybe we can pop it up or link to it,
Yeah, like
they categorize different drownings and kind of where you are and what the recommendations are as far as observation, supportive care, admission, ICU, or death. But they definitely mentioned that, this is respiratory and we should start with breaths, which is definitely not what we currently do with CPR.
Yeah, yeah, I guess
Moved
we're just
away.
full circle in some
Yeah.
ways.
Most pediatric emergencies, though, are respiratory.
Right.
Despite the fact that we start with CPR, the majority of pediatric cardiac arrest are still respiratory. So I don't know, I'll be interested. I know you were a medic. I was also an EMT. Like, I'll be interested to see if we ever circle back to that in pediatrics.
Yeah, and I think, just anecdotally, like that they're moving away from this because people don't want to put their mouth on a stranger, and it's
And
like
they just
there's
don't do it. Regardless if it's recommended, it seems like it's just not done,
okay,
I
interesting.
think. That's
I
yeah.
always thought like I would not, am I going to do mouth to mouth on somebody at Walmart? Probably not. If it's my neighbor or a kid,
Yeah,
I'd probably be more likely to do that if it was a 3-year-old kid. I don't have to worry about all the grossness that comes with being an adult.
correct.
Okay. Well, that's a great segue sort of into this prevention part, which I know you have a big role in child safety. What is it that you do?
I established with several of my colleagues Children's Injury Prevention Program through Children's Healthcare of Atlanta. It's a multidisciplinary kind of approach to different injury patterns throughout, really focusing on the most common causes of death throughout Georgia nationally. I've been lucky also to present with COVID, which is the National American Academy of Pediatrics kind of Council of Injury Violence and Prevention, and been involved with that for about 15 years now. I just am very passionate about injury prevention and have a really great group of colleagues that we've really worked to put this forward in Georgia and hopefully nationally.
Yeah, and I looked at the statistics by state last night, and Georgia's actually, I just assumed because we are in the South and we're bad at everything, that we'd be on the highest, and Georgia's not. It's on one of the lower as far as incidence of drowning deaths. It was lower than Tennessee. So,
Yeah. We have we do have water, of course, but we don't have quite as many like small pockets. Like definitely around Gainesville, there's a lot. But yeah, it's interesting. Florida obviously is very
mhm.
high, and it's such a hard prevention, as we'll talk about, issue to deal with. It's much different than a lot of the other prevention issues we talk about with injury.
Yeah. And these fatalities are devastating, right? In part because typically the adult is standing there. You can't help but just beat yourself to death when if something happens to your kid, we are first to blame ourselves. But what can we do to prevent drownings? How can we educate families in the emergency department about this type of prevention?
So, the most important thing I like to say is there's not one way to prevent drowning. So, it's really what we call layers of protection and looking at making sure we're overlapping as many of these layers as possible to prevent your child from drowning. When we talk about gun violence, locking up the gun, removing the gun, storing safely, and that's it. Like a gun injury cannot happen if those things are done.
Hmm.
But if you do swim lessons, you can still have a drowning. If you know CPR, you can still have a drowning. So there's so many layers required to keep your child safe from drowning. And I think that's what makes it such a complicated issue. So, the first thing I like to talk about is what we call arms reach, eyes reach, which is really just making sure we have really great supervision. And that's making sure that you have a way to know that if your child cannot swim, what I like to do a home swim test. So, every summer before your child gets in the pool, if they can swim 2 lengths of the pool, then you can go to what we call eyes reach supervision. You can watch them from the side. If they cannot swim 2 lengths of the pool, then you need to be within arm's reach of them at all times. And that's our biggest takeaway that we've come up with because that's really going to be the most effective way of preventing drowning.
Yeah. So if they're not proficient swimmers, you really need to almost be in the pool with them.
No question, you need to be in the pool with them. You need to be able to grab them. Different types of life jackets and Coast Guard approved life jackets, that still won't 100% prevent drowning. Swim lessons won't 100% prevent drowning. And in fact, we only have really one study, and we can link to it. It's called the Brenner study that shows risk reduction with swimming lessons because we just don't know. And the way that they did that study was saying, calling people whose children had drowned and asking if they had ever had swim lessons. And they found that the kids that did, there were way more kids that had not had swimming lessons that drowned as compared to kids that had swim lessons. And they called that an 88% risk reduction. And that was just based on, that was it. That's the study we got. We got nothing prospective. It was like, I think 200 kids, like that's all we got. So we have all these recommendations, but really the only thing that we know that's really effective is truly this very tight supervision.
Do you find that's hard in this day and age when we're so distractible?
It's really hard, and we're also trying to instill those skills in our kids that they can be self-sufficient, and we have this whole anxious generation, and we want to provide our kids safe risk-taking chances so that they can gain skills and show their strengths. So, it's a really hard balance as a parent, no question.
We touched on this a little bit earlier, but let's do a little myth busting with regard to dry drowning. I feel like this comes up every single summer. It typically goes a little like this. I'm bringing my daughter in tonight because she doesn't look good and she has a cough. I'm worried because 2 days ago we went to the water park and she seemed to swallow a lot of water. I'm worried that this is a dry drowning. How do you address this with parents?
First of all, I like to say dry drowning, unfortunately, is I know that you've been told about dry drowning, but that is not a thing that exists. That term doesn't exist. It's been gone for years. It's something that media, unfortunately, has continued to put out. Luckily, in Atlanta, we've actually been able to chop it off because I've done a lot of the interviews and we've pushed out a lot of information about it. But it's something that really doesn't exist. And then I actually love to show them our protocol for our submersion injury and show them that if there is a real drowning, it's going to show progression within 6 hours. So the fact that they're coming in 2 days post, we automatically know that this is not related to a submersion event or an aspiration event. So I really like to use any sort of evidence I can to show them and walk through what our typical protocol is.
Yeah, I thought it was interesting when I just randomly last night searched on Instagram dry drowning just so I could see what are people saying? Like where
Yeah.
is it what are their thought processes? But what was most interesting to me is that this was actually rooted in medicine. There was that terminology at one
Yeah.
time, right? It was and they also called it delayed drowning or no, secondary drowning.
Yeah, both. They had both terms. And that's where we talked about that laryngospasm, right? So basically, what they found is that some people didn't have an initial aspiration. They had this laryngospasm. Regardless, they still had hypoxia, and eventually the laryngospasm went away and water was aspirated. But that's where that term came from. But regardless, it's the same pathophysiology. There's still going to be washout. There's still going to be surfactant washout. There's still going to be issues with oxygenation and ventilation. But a lot of the dry drowning stuff that came out in the media over the past few years really was like, my kid had an event, I didn't seek care, and then 8 hours later we went in when they were in distress. That's not dry drowning or
That's a real
delayed
drowning.
drowning. That's a drowning that we just didn't seek care for right away. And
Yeah.
that's the reason we watch for 6 hours.
And I think that's going to help me moving into this year with a little bit of scripting. I think parents a lot of times just want to hear us validate their concern. And I think to be
Absolutely.
able to say that was a thing in medical literature from many years ago, but what we have learned is XYZ, and this is why it's safe or why we don't use that term now is a lot nicer than saying that's not a
That
thing.
doesn't exist. Yeah.
You're wrong. You don't
Yeah.
know.
Yeah. And I think just emphasizing like you watched for the signs, you brought them in, and now we can be reassured because we have passed this time limit, which we
Yeah.
know when we think about delayed drowning or dry drowning. This is the period of time that drowning evolves because it's an evolving process.
Yeah. I love that. What would you say, as a recap here, are the biggest takeaways or pearls that you can give for our clinicians out there about submersion injuries?
So I think the number one thing is for prevention strategy, we know there's not one way to prevent drowning. You're not going to drown proof your child. So really focusing on telling parents all the ways that they can save their child from drowning. So one, close supervision, doing home swim tests before they go out, being honest about their swim abilities when they're with friends. If a child can't swim, be very clear that they should be in a life jacket and that they do not have those swimming abilities. Really focusing on risk taking behaviors with older kids. And yes, swim lessons are great, but knowing that is not necessarily going to drown proof your child. So that would be my biggest takeaway is that Unfortunately, there's not one way to make your child safe from drowning. We really have to be multidisciplinary and look at all the different ways to do that. So that's the biggest prevention message. And then the second message is that drowning is a process, it's an evolution. It can happen over a period of time. So if a child experiences an aspiration event and respiratory impairment, then they need to be observed for 6 hours or so and see if they develop symptoms. And if they don't within that period of time, then the symptoms they may develop the second or third day are probably more likely viral rather than related to any sort of drowning event.
Thank you guys for joining Dr. Lazarus and I today to talk about submersion injuries. Now join us next month when we're going to have Dr. Shelley Murphy on to do a case-based episode. We had a little change in the schedule that was supposed to be this month, but we flip-flopped it and we're going to do it next month. So we'll see you back here in May. Any opinions expressed on today's podcast are solely those of the speaker and do not reflect the opinions or policies of any employer or hospital system. In many states, advanced practice providers work collaboratively with physicians. One should always be careful to consult with your physician leader when it's appropriate. This podcast was designed for medical education purposes only. Its speakers have made every effort to provide the most current and evidence-based information. However, that should never replace one's own effort to validate current evidence-based practice before implementing a plan of care. Any pathway or algorithm that we may have discussed may not reflect those of your healthcare system. Please be aware that these may change based on your geographic location or current employer site. This podcast was not designed in any way to provide medical advice or treatment plans for patients and their families. If you have a medical concern or an emergency, please be seen by a local medical provider or call 911 for assistance.